I'm Miss Sue Green. I'm Consultant Colorectal Surgeon at the University Hospital of North Durham, and I'm also Lead Cancer Clinician for County Durham and Darlington NHS Foundation Trust. The surgical stress response induced by major surgery is comparable to that of running a marathon. We wouldn't run a race without adequate preparation and training, and likewise we should approach surgery in the same way. The importance of adequate preparation, or prehabilitation as we often call it, has been shown to be very important, not only in just elderly patients who often have other health problems and are also often frail, but it's also been shown to be very important in younger, fitter patients. As far as the surgical pathway is concerned, there are three major components. Firstly, prehabilitation. Secondly, enhanced recovery. And thirdly, rehabilitation. It is important to optimise patients medically, for example, correction of anemia and good control of blood sugar in diabetic patients. Physically, where possible with tailored exercise programmes, but self-management fitness regimes are also encouraged. Psychologically, with support, reassurance and relaxation techniques. And nutritionally, including dietary advice. This may involve weight loss, but does focus on increasing muscle mass. We also include help to stop smoking and also help patients to reduce alcohol intake where appropriate. There is good evidence that prehabilitation improves patient outcomes in terms of reduced length of stay, improved quality of life, and faster return to preoperative baseline. Prehabilitation also empowers patients to engage in self-management. This is important as patients often experience a loss of self-control when they receive a cancer diagnosis. Cancer weight targets do mean that we often have a limited period of time in order to prepare patients for major surgery. There is good evidence, however, that a shorter period as 2 weeks is often sufficient to improve patients' cardiovascular fitness and also improve things such as muscle mass. Changes to surgical techniques are important, and this includes keyhole surgery and smaller incisions. Optimal anaesthesia is important, including adequate pain control. Intensive earlier physiotherapy and mobilisation also improve patient outcomes, as do early nutrition, and we aim to recommence patients on oral diet as soon as possible after surgery. Rehabilitation is also very important. When patients are discharged from hospital, they often feel as if they fall off the radar. If patients can slot back into an actively managed, adapted rehab programme, then it's much easier for them to recover from their surgery as they feel supported both emotionally and physically. Although enhanced recovery is well established in most hospitals, prehabilitation and active rehabilitation programmes are still in their infancy. The evidence to date, however, does support these programmes to improve outcomes not only in surgery for cancer, but also in other cancer treatments, for example chemotherapy and radiotherapy.